Good morning and welcome everybody. I am Maria Muller, President of Moffitt Foundation. Thank you for joining us for this virtual gathering, which is taking the place of our annual Sarasota Luncheon. We certainly miss seeing you all in person, but I'm pleased to have this opportunity to thank you for your support for Moffitt. As you may know, last year we established a research innovation fund to gather support for some of our most cutting-edge research that will impact the lives of so many patients today and tomorrow. Support from the Sarasota community will be used to help some of our most innovative ideas and our top priorities, and you'll hear more about those priorities from our new CEO, Dr. Patrick Hwu, in a moment. With the arrival of Dr. Hwu, it's becoming even more clear that Moffitt is truly at the forefront of medical science. And in the years to come, we are going to make significant headway in the fight against cancer. It's so important to us that communities throughout Florida have the opportunity to learn about our work and support our work. And the Sarasota Luncheon is an excellent example of this outreach and partnership. Our goal for this year is 200,000, and I'm thrilled to say that we have already reached 196,000. So we are almost to our goal, and we really hope that we might exceed it today. And just let me thank some of our incredibly generous donors that I hope you saw at the beginning of this program on the screen. A shout out to some of our important donors today: Eileen and Howard Kurd, Marty Nealon and Richard Allen, the Gulf Coast Community Foundation, Jeannie and Tom Russell, Elita Kranz-Kane, and Barbara Savasio. I would like to give a special thank you also to our fabulous committee who have worked so hard to spread the word about Moffitt and have really led by example in donating themselves to this event. After we hear from Dr. Hwu and Dr. Fleming, our speakers have completed their presentations. There'll be an opportunity to ask questions. We really want this to be an interactive session, so please do put your questions in the Q&A button at the bottom of your screen, and Liz Howard will facilitate that session. So next I want to introduce Eileen Kurd, who's really been the driving force behind this group since it gathered for the first time in 1998. Eileen's enthusiasm and commitment are contagious, and she deeply cares about our patients and about the mission at Moffitt to make curing cancer a real possibility. So let me now share a message from Eileen, who is our event chair and a Moffitt Foundation board member. Thanks, Eileen.
Hi and welcome. I'm Eileen Kurd, and I'm thrilled to welcome you all here today and to let you know your support over the years by funding new research and treatments has made a huge difference in the way we treat cancer patients around the world. You are truly saving lives. This has been quite the year. We were hit this year with a pandemic. But sadly, cancer does not stop for COVID. The good news is neither does Moffitt. We've continued our efforts to fight cancer full force. And this year we treated over 6,700 patients from Sarasota, Manatee area. That's even more than previous years. 6,700 people. These are your families and your friends. These are the people we know. It takes a great leader to oversee a cancer center like Moffitt. And we certainly have found that in Dr. Patrick Hwu, who joined us this November as CEO. Dr. Hwu came from MD Anderson in Texas. There he led the Division of Cancer Medicine, the largest oncology group at Anderson. Dr. Hwu has over 33 years of oncology experience, and in research, he helped pioneer the field of gene-modified T cells. As an internationally recognized physician scientist, he has a track record of leading teams to make breakthroughs in science and breakthroughs in improving outcomes for cancer patients. And if that's not enough, Dr. Hwu is president-elect at the Society for Immunotherapy of Cancer. He serves on the Melanoma Research Alliance Advisory Panel in DC, and he's a member of numerous scientific advisory boards throughout the United States. As Moffitt board chair recently put it, Dr. Hwu is highly motivated to ease the world cancer burden. It is an extreme pleasure of mine to introduce Dr. Patrick Hwu.
Thanks so much, Eileen. And hello, Sarasota. Really happy to be here today. You guys are legendary in your support of Moffitt Cancer Center. And really, I'm honored to be here. And thanks, Eileen and Howard, to supporting this event year after year. Eileen, you're just inspirational and infectious in your enthusiasm and support for cancer research and the Moffitt Cancer Center. So I migrated from Houston, Texas, at a small cancer center over there to come to the next world's greatest cancer center here in the Tampa Bay area, Moffitt Cancer Center. There's just amazing potential that we have here. I think in the first 35 years, largely to your support, we've gotten the rocket on the launching pad, and now we can just take it to further heights. I'm really looking forward to this over the next few years. In the first 35 years, what we've done is the death rates from cancer have just started to plateau, and for 2 years in a row are starting to come down. What we hope in the next 35 years is to drive those death rates down to zero. We really think we can. And through your help, why wait 35 years? Let's compress that time frame. I think we can. I really think we can. I think one day deaths from cancer may still happen, but they'll be like deaths from bacterial infections. They still happen, but then we think, wow, that's a little unusual. Death from a bacterial infection. That's what we really hope to get to, and I know it's realistic. In my own field of melanoma, that's already happening. My own clinic, where melanoma starts on the skin, spreads everywhere, used to turn around every 6 months because my patients would pass away. But over the last few years, we've really improved the therapies by stimulating the immune system. And over half of my patients now are essentially cured, living long, healthy lives. And so we just want to get that to happen with every cancer, including the tough ones like pancreatic cancer. So you'll hear from Dr. Jason Fleming today. He's an outstanding guy, one of our most talented physicians and researchers here, who will talk to us about pancreatic cancer and the immune system. But we have many other programs as well planned in the upcoming years. One is continuing our vaccine research. As hopefully all of you are getting COVID vaccinated. And if you're not, just let us know. We'll arrange for it at Moffitt Cancer Center if you need to. We have plenty of vaccines in the freezer. This technology is not new. The RNA vaccines have been used for cancer research for many years in clinical trials. So actually, cancer research led to the COVID vaccine, which we're very proud of. And I think we're going to learn from the COVID vaccine now how to bring that back into cancer. So vaccines and immunology, something we're going to really go big on. Cell therapy, where we take immune cells like soldiers, have them do the kiss of death onto a cancer cell, and then go to another cancer cell, the kiss of death. That's what Dr. Fleming's going to talk to you guys about. We're also trying to eliminate and eradicate HPV, which really my daughter's generation, they're 20 and 22, none of them should get an HPV related disease. In that whole generation, cervical cancer and a lot of the oral pharyngeal cancers, that should be a thing of the past if we really eradicate and disseminate this vaccine. Other areas that we're working on is metabolism including the question I get asked from every single patient, and we still have to do more research to figure it out, is what should I be eating? So we're going to get a food kitchen and start to really monitor and look at research and what should people be eating? How can we synergize? I think food is medicine. So how can we synergize what we eat with the kinds of therapies we get to try to synergize those and also affect the bacteria in our guts? We're actually made mostly of bacteria, that we have so many different species of bacteria in our guts, and the kind of bacteria we have really matters in cancer care. We're just learning about this new area. We recruited some really wonderful faculty, which we'd love to introduce you to study that. That's just the tip of the iceberg of what we're doing and how in the next 35 years, and hopefully sooner with your help, drive these death rates down to zero. And I'm confident we can do it. Now we're going to hear from my good friend, Jason Fleming. Jason also migrated from Houston a few years ahead of me. We were working at the same cancer center, MD Anderson there. So I've been a friend of Jason's for a long time. I've been an admirer of his. He just is one of the world's best pancreatic surgeons to begin with, but also a wonderful leader. He has an incredible department, and he has plans to take pancreatic cancer down. And so I really appreciate having Jason here and being able to reconnect with my good friend here. So take it away, Jason.
Thank you, Patrick. And thank you all for sponsoring this event. This type of work cannot be done without philanthropic support. The idea here is to take the fabulous work that Patrick has and his colleagues have done for years, and now it's time to make a cure for diseases that have been thought to be incurable, and pancreas cancer is certainly one of them. This work is performed in my laboratory and the laboratory of Dr. Sherry Pilon Thomas, who's an expert in tumor infiltrating lymphocytes, which we'll talk about. Let me advance this here. There we go. So what can ecology teach us about doing this? So we have an evolutionary biology group here at Moffitt, and they have inspired all of us to think about cancer in a different way. And if you're trying to cure a cancer, the analogy is it's the same thing as making a species extinct, which unfortunately happens most of the time. So it gives us a template to learn. So while species becoming extinct we kind of think of it as a bad thing, for cancer, it's a good thing. And there's lots of analogies we can learn from. So, and reading about this and learning about this, I didn't know that most animal species have become extinct in the world. So they exist for a while and then they die off. So these are 4 examples. How does it happen? So ecologists have studied this for many years. And the way it works is you have a population here, and I have my cursor over, it has a population, a number of animals that are living. And then there's some event that happens. Could be a change in climate, could be habitat change, could be some infection, and there's a die-off of the animals over time. And there's a pivot point here called the minimal viable population, where the conservationists know that if the animal population gets lower than that, there's a greater than 95% chance that that species will become extinct. If they don't, they'll recover. And that happens in different scenarios. When that happens, when a species gets close to its demise and then it recovers, there's something called a founder effect, where the population that was here is very diverse. And when they die off, you lose certain subsets of that population. And then the recovery, you get you get populations that are more identical to each other genetically, and they lose that diversity. An example is the heath hen. So heath hens used to live on the coast up in the Northeast, along Delaware, New York, and they lived in the marshlands next to the ocean. And they were easy to catch. So people ate them because they were hungry in the 1600s. And what happened is the population got so small that they were almost going to be extinct, and they were a beloved population. So some conservationists moved them, a small group, to Martha's Vineyard, where they had a colony. The problem is that colony had the founder effect. And unfortunately, in the 1920s, a couple of events like a fire or some predators, and the heath hen became extinct. So that's our own history. When you think about cancer, the first strike is radiation, chemotherapy, surgery. Those are the big things we do where we try to kill a bunch of cancer cells. When it recovers, for us, that's recurrent cancer or metastasis, spread. What we're looking for is this down here, this extinction or cure of the species. Well, how does that look in pancreas cancer? Well, so here's a pancreas. This is like we're looking inside someone's abdomen. There's the liver, there's the bile duct. So pancreas is right here. Let's say there's a tumor right here, and there's a population of cells. This is a histology picture of a pancreas cancer. And you see all these little guys. These are all cancer cells. And what we're learning, and actually the evolutionary group is publishing on, is that the cancer cells that live over in this neighborhood, think of these as like a bunch of cul-de-sacs, and you're looking at a Google map. There's all these different, these are all different people living in different areas, different neighborhoods. And so the cells are different when they live in a different neighborhood, and they're different in their susceptibility to extinction. So a similar parallel in ecology are the lemurs on Madagascar. There's 110 species of them. They live all over the island, and they got there a long time ago during Pangea. What's happened is, so when we give chemotherapy and radiation, it's the same as habitat destruction of the lemurs. And when they map that, you get lemurs that are used to live in spaces, but now they're gone, and you get these little colony remnants. All the gray are where the lemurs are still living. Fascinatingly, after we treat tumors with chemotherapy and radiation, we get a histology that looks like this, where all of this is dead stuff. It's like habitat destruction. But there's these cells that remain, these guys that are living, just like the colonies. And that's how cancer comes back after you treat it with these traditional modalities. The other way cancer comes back is spread to other areas. So even though we may have a cancer that's here, we know, and we actually can demonstrate that there's cells that are leaving this cancer and going through this vein and seeding this liver up here. And these cells will grow into new colonies up in the liver. Now, the good news, that's how most patients have cancer come back, with GI cancers at least. Large majority of them come back in the liver. The good news is that it's kind of like the Galapagos finches, and you get that founder effect that we're looking for, where these cells get out of Dodge here and they go over to the Galapagos Islands. So they're up here in a foreign land, and these cells will grow as a colony. So this is our cell moving, and then it grows into a colony. And that happens, we know that thousands of cells leave the primary tumor and go up to the liver every day. when someone has a cancer that's intact. It's pretty scary. Your body kills 99.9% of them. How does it kill them? It kills them with these lymphocytes, these cytotoxic cells that know how to give the kiss of death that Patrick was talking about, where you have the antigen on the surface of the cancer cell, which is the green. This T cell knows how to recognize that antigen, go in, and then it kills this as foreign, recognizes it as foreign and as a target, and kills it. So actually, your body's pretty good at defending itself, just sometimes not good enough. So that's where we come in. So what we want to do is, your body makes these TILs. So these are tumor infiltrating lymphocytes. If you look up here at the right-hand side, and these lymphocytes go into the tumor and they kill cancer cells repeatedly. The problem is they're being overwhelmed by the number of the tumor cells. There's millions, if not billions, of cells and they can't kill them all. And so what happens is the cells get to escape, and these micrometastases in the liver are forming. So what we want to do is leverage the fact that there's T cells that already know how to kill cancer cells. There's just not enough of them. So we're doing this now. We're taking the tumor out. We grow the tumor in the lab. So Dr. Pilon Thomas grows the TIL. She grows the T cells. I grow the cancer cells. And this is the cool part. And then in the lab, we basically train these T cells to recognize what we want, or to recognize the tumor cells to make their killing capabilities better. So it's like going to T cell school, and we train them to be predators, to be better predators. It's like, a mama wolf teaching the baby wolves how to kill. So we're teaching them how to do this, and then we create a reagent that we're going to give back to the patients after they've had surgery to sweep up these micrometastases that we know are there. So the idea is that we're going to use standard therapy to push the population to extinction, to get down toward that minimal viable population number. So the chemotherapy, we will still use the chemotherapy, radiation, surgery, other techniques. But we know that, unfortunately, when we do those, 80% of the patients will have recurrence. So we know that there are cells outside that we need to sweep up. And so we will train a wolf pack that we will send in of lymphocytes that have been trained to kill this particular, the cancer that's in that particular patient, which I think is unique and very important. And we will give these to that patient, and we will drive that population of cancer cells below that minimal viable number for a cure. And that's our plan. Obviously, this lab work takes resources. Building this is like building the first atomic bomb or building a rocket. Everyone knows it probably should work, but you have to actually build it and show that it works. And that's where we are. And that's why this event and events like it are so important. And with that, I'll turn it back over to my boss, Dr. Hwu.
Thanks so much, Jason. Inspirational as always. Now I'm going to hand it off to Liz, who's going to be emceeing our question and answer period.
Absolutely. Thank you, Dr. Fleming and Dr. Hwu. We'll now move on to the Q&A portion of the event. If you're interested in submitting a question for either of these wonderful physicians, please use the Q&A icon on the bottom of the screen. And I will go ahead and facilitate. It looks like we already have some, so we'll kick it off. For Dr. Hwu, what is the next big thing in melanoma research?
Thank you. That's a great question. Although I think we're curing people with advanced melanoma, about half of them right now, the other half we still have to work very hard with. And so we're going to do combinations of therapies, combining immunotherapies with targeted therapies, which are often pills that take off the circuitry or cut the circuitry down of the tumor cells so they can't proliferate and grow. The other thing is the cell therapy that we've been talking about. We think this year that Iovance may have a FDA approved melanoma treatment with cells, something that we really help them with their tumor infiltrating lymphocytes, just like Dr. Fleming was talking about. But there's so much more we can do. If you think about these cells as soldiers, we can make these soldiers much better. Sometimes they get into that tumor and there's the tumor smart, making a lot of toxic substances that can really either kill them or make them so they can't function. So we're now taking out genes, putting in genes to fortify them, make them super soldiers. It's like putting a gas mask on our immune cells. And so when they go into that battlefield, the toxic substances that the tumor is making doesn't affect them anymore. So we've started doing that in melanoma. My own lab is going to be working on melanoma, triple negative breast, pancreatic, glioblastoma, but we've started really with melanoma and triple negative breast to try to make these super soldiers against cancer. So those are just some of the fun things that we're doing.
Thank you. Has the TIL therapy Dr. Fleming spoke of being used on any other forms of cancer, like maybe non-GI cancers, and what are the effectiveness of that?
So Dr. Hwu's gonna, so the effectiveness in melanoma, I'm gonna let him talk to you because he's a world's expert. We're just starting to use it in GI cancers. So this is all developmental, not prime time yet, but coming soon for us.
So melanoma, we hope that it's going to be approved this year. We'll see. The other group that we have is in our lung cancer group. Ben Creelan, would love to have you hear from Ben at some point. They've done this in lung cancer. So just like Dr. Fleming described, they're growing these immune soldiers out of the lung cancers, growing them to large numbers and then infusing them back. They've had quite a few successes with that. So we hope that one day will become standard therapy. Other cell therapies that we have is sometimes we take just immune cells from the blood and put the genes in those, called CAR T therapy, where we can redirect those cells to kill tumors. And that's already changing the standard of care, because I saw a question there about the standard of care. In lymphoma, that's changing the standard of care, cell therapy. And there is just an approved therapy for myeloma, another kind of therapy that attacks our bones often, tumor that attacks our bones, myeloma. And that standard of care, we're probably going to be the first in the nation to offer myeloma CAR T therapy as standard of care here on our cell therapy unit at Moffitt.
Looks like another one that might be a question for Dr. Hwu. How does therapy affect the standard of care at Moffitt?
Yeah, so our only goal is to bring in research therapies and make them into the standard of care. So when we did this study with Iovance, the whole goal was to help them get FDA approval, because only when there's FDA approval can we expand these and scale these to the masses so they can be done worldwide. So every therapy we do, Dr. Fleming's therapy now is experimental, but we hope one day that's going to get FDA approved and become the standard of care. What we did with the CAR T therapy, Fred Locke, in our heme group, in our BMT group, took that from research to leading the efforts to make that standard of care for some really tough to treat lymphomas and now myelomas. And so now those are becoming standard of care. And so that's just the trajectory. We go from lab to clinical trials to standard of care. And then we do the whole thing again to try to make the next treatment standard of care. And working together with all of you, we're going to continue to drive that death rate. Because I said, 2 years in a row now, that's starting to decrease for the first time because of the advances in melanoma and lung cancer therapies. And hopefully we can drive that down to zero together.
Thank you. Dr. Fleming, is there any treatment for pancreatic cancer patients who are not candidates for surgery because it metastasized? And also, are there any new effective chemo treatments that were not available 3 or so years ago?
So if you know about let's say breast cancer or lung cancer now, the way the field is going is we're learning about different subsets of each cancer. So we used to think of it as breast cancer or lung cancer or melanoma, and now with the molecular work that people have done for years is just now hitting these cancers to where we can put them into buckets and then treat them by their genetics, not just by how they look under the microscope. So pancreas cancer we're a little behind, but we have 2 or 3 groups that are starting to be called out and targeted. One is something called a DNA damage repair group. So there are certain genetic mutations that make these tumors susceptible to certain types of chemotherapy. And so at Moffitt, we regularly test for those. So we're looking for every avenue, even if it's, and that's only maybe 10% of patients. But hey, if you're one of the 10, that's 100% for you, right? So if we can figure it out for that one patient, we're going to go that extra mile. So that's one avenue. The other is at Moffitt, we identified that so almost all pancreas cancer, so 90% have a mutation in a gene called KRAS, but there's 10% that don't. And the 10% that don't get these special genetic changes that can make them super sensitive to drugs that are already FDA approved. And you have to figure out what it is. So it's a little bit of I tell patients it's like cracking a safe. We gotta crack each one. And so we do that genetic testing. So what's happening is we're chipping away at these different subtypes, and we're going to turn around and it's going to be, well, we know for half the patients, we know exactly what kind of chemo to get. So that's a long answer, but that's the direction of the field, so that not everybody gets brand X or brand Y. We get brand X plus, brand Y plus, So that's and we're seeing the results. So that one example of the genetic fusion is what it's called. We had a patient who we were treating here who had really cancer spread everywhere inside the abdomen and really suffering. And we put that patient on a medication that had minimal side effects, and and basically cancer disappeared in that patient. Now, how durable would that be? We don't know, but it changed his world and made his life a whole lot better. So that's our goal.
Thank you. This one's for the both of you. How close is Moffitt to becoming referred to as the place to go when seeking out pancreatic and melanoma cancer treatments?
Well, I think it already is. In some ways, Moffitt Cancer Center is the best kept secret in the land. I knew it was a great place, but now that I've been here 5 months, I can tell you it's an exceptional place. It's the place to go. And as we get these novel trials off the ground, cell therapies, for example, that you can't get anywhere else. This pancreatic cancer cell therapy trial that Dr. Fleming described, you're not going to be able to get that anywhere else. It's going to more and more become the place to go. And all of you help with that. I know Eileen and her energy is doing that for us in the Sarasota area. I see Marty on the call, and Marty's doing that for us in New York City. But as the secret gets out, we'll have more and more people flying into Tampa Airport and coming to Moffitt Cancer Center.
I would just say, I was talking to a patient actually in clinic yesterday, and they asked that question. And the way I think about it is, when you come to a cancer center like Moffitt, you've got 7,000 people. All we do is think about the things we just talked to you about. That's why it's easy for Patrick and I to talk to you, because that's all we think about. And the whole place has people. So you're a pathologist, your radiologist, your anesthesiologist, you're the guy who's parking your car at the valet. All of us are thinking about helping you defeat the cancer that brought you here to see us. And I don't think you can replicate that with the cancer center attached to the general hospital. I just don't think you can. And so I think it's I don't have any doubts about I don't have any doubts about the GI cancer part. In this part of the country, this is the place.
Wonderful. Dr. Hwu, we're hearing great feedback on the food lab concept. Do you anticipate needing participants in any sort of trials or tests for this food learning, and how else can they help?
Oh, absolutely. We just cannot wait to get this off the ground. And Armin and Tiffany are wonderful new recruits that we would love to introduce to you guys sometime that are going to lead this effort. We'll need all sorts of people, from philanthropy to tasters. I mean, once we were doing this and everything tasted great except this kale shake, which was just horrible. So we gotta just make sure we make it palatable. That's important. And then we will need volunteers who will agree to just eating what we give you for a number of weeks, including snacks and everything, because we'll want to measure a few things. And so, when you're out with your friends, you'll have to bring your little baggies of food that we give you. And then that way we can totally understand what a diet does to the bacteria in the gut and how that affects blood levels of different things. So I think what we eat might potentially drive cancers if you eat too much sugars, for example, and drive that insulin up and the insulin growth factor, those proteins up. Tumors love that. In fact, a PET scan, you guys heard of a PET scan? A PET scan is simply when we tag sugar molecules with radioactivity and we have the sugar go find the cancer, because cancer just loves sugar and just takes it up. And so oftentimes I can't see a melanoma on the CAT scan, but when we tag the sugar, it's just eating up so much of that sugar that there's the melanoma right there. It's so obvious. And so I think because cancers love sugar so much, that's one of the areas that we're going to be studying here. But we're going to need lots of volunteers and participants. Once we get this up and running, we're really excited about it.
Wonderful. What is the treatment for ocular, or I should say, what is the standard treatment for ocular melanoma that has typically spread to the liver or lungs?
That's a really good question. Melanomas, different kinds. The majority of melanomas start on the skin, called cutaneous melanoma, and that spreads. But there is a melanoma, it's rare, but it starts in the eye. It starts in the back of the eye. And that, interestingly, mostly initially goes to the liver if it's going to metastasize. Now, when it's in the eye, we can tell if it's in danger of metastasis or not by the genetic testing of it, just like Dr. Fleming was talking about genetic testing. So we do that on every melanoma that we see in the eye. We get genetic testing. But if it spreads to the liver, there's no standard of care right now to try to prevent that. There's a lot of local therapies we can try, but we are studying, there's a lot of studies for taking these T cells to infuse them. We even have done a study trying to infuse those cells up into the hepatic artery to deliver them directly to the liver, because this is where the cancer spreads to. So I think we don't have a standard of care for ocular melanoma once it spreads to the liver, but I'm in great hope that cell therapy, like we're describing today, will one day be the answer for it.
Thank you. Dr. Fleming, what are the warning signs of pancreatic cancer, and what can typically be done to prevent it?
Right, so awesome question. It's been over the years kind of been the silent killer where they're not great warning signs, but we're learning a little more. Traditionally, the signs were that the tumor was pushing on the tube that drains the bile, so jaundice, unexplained jaundice or yellowing of the skin. But recently, to the point, to Patrick's point about metabolism, we're learning that there's a warning sign of new onset diabetes in patients or in people who don't necessarily fit the profile of somebody who might be at risk of diabetes. So it's a little bit of a shot in the dark, but we tell patients, if you're newly diagnosed diabetic and you don't have a family history and you're not overweight and you don't have an obvious reason, about a large percentage of those patients are diagnosed with pancreas cancer within a year of that diagnosis. So that's something that I think the medical community needs to be more aware of and more vigilant about, because a difference in 6 months or a year for a pancreas cancer is the difference between spread to the liver that Patrick's talking about with melanoma and not, and it totally changes your options. So prevention, we're learning more about family history and risk. So I mentioned the genetics. We know that there are certain genetic inherited syndromes. So these are genes from mom and dad, either mom or dad, that you get that puts you behind a little bit behind the curve on your risk, meaning you're higher risk at baseline. We use what's called a relative risk score. And there's some of these genes that put you 10, 12 times higher to develop pancreas cancer in your lifetime versus someone else. So we've developed a screening clinic that's designed to focus on those patients and kind of individuals, really, they're not sick, but pull them out of the pool of everyone and focus down on what's happening with them, because often they get changes in the pancreas that you can see on imaging, a CT scan or an MRI that we can use to gauge kind of where they are in this curve. And some of those patients, we end up taking their pancreas out really before they have pancreas cancer. So more to come on that. We don't have the pill yet that could lower your risk. One thing, but we know inflammation in the pancreas is a driver in every animal model and every model we have. So I tell patients, moderate, I call it the no fun diet, very moderate alcohol, very low fat. Mediterranean without so much wine, something like that. But right now, that's where we are.
And Jason, what about the role of obesity and smoking? Are those risk factors for pancreatic cancer?
Absolutely. So those are described. So in the relative risk score, smoking, just like lung cancer, there's a dose effect for packs per year that increases your relative risk. And obesity also, especially early obesity at childhood, early 20s, is a definite risk factor. In fact, pancreas cancer was traditionally kind of lumped in the smoking cancers, and now it's more of a metabolic cancer. We think that if you've heard of fatty liver syndrome, it's kind of like that. So it's just driving inflammation through metabolism.
Wonderful. Dr. Fleming, another one for you. Are the treatments and therapies different for those who find pancreatic cancer early?
Right. Like I said, you have the earlier we diagnose the tumor, the kind of more options are available. But honestly, the therapies are right now, the mainstays are going to be systemic chemotherapy, plus or minus radiation, plus or minus surgery. Like I showed on the presentation, if you give chemotherapy and radiation alone, you can kill a lot of the cancer cells, but remember that habitat, there's always some guys that survive. So if you have a localized smaller tumor, we have a chance to perform surgery and actually, remove the whole habitat. And currently that gives you the best chance of being cured. So earlier the better.
Perfect. Dr. Hwu, how do you plan on educating and involving the community with that healthy kitchen? It keeps coming up.
Yeah, it's a really very important area. We're focused on disparities, and there really is divergent outcomes from cancer depending on your zip code. It's really not okay that you can just plug someone's zip code in and then you'll know how they'll do with cancer across the country. It's really, that's not okay, because people can't always control where they live. So there are areas of food deserts where there's just no nutritional areas, no grocery stores, no Publix, nothing except, McDonald's. And so we have got to get out to those areas, and we have an outreach group led by Dr. Susan Vada-Parampil, who is specialized in going out to these communities And so that's the key, is we have to reach everybody, teach everybody about vegetables. Some people don't even know how to prepare vegetables, green vegetables and other things like that. And so we have to have, our goal is to reach out and educate as part of this food kitchen. We'll have a demo kitchen there with a mirror and everything so that people can come in and we can show them. And I'll even show them how to stir fry. That's the only thing I know how to do. I can make omelets and stir fry. So I'll do that part, but otherwise I don't know how to. It'll have to be left to the professionals.
For both doctors, and this will be our last question for the day, how can Moffitt improve communication between the different silos of treatment, such as pain management, oncology clinics, general practitioners, etc.? This is sometimes different info coming from different sources, and so it seems to be a bit confusing for our viewers. And so they're just trying to figure out what is key.
Well, if there's some issues with the communication, I personally apologize for that, because we should all have one voice and communicate very well. I can tell you, as we grow, this is continually being a challenge. We need to grow because there are many people trying to get into Moffitt. We need to grow. Jason and I were just talking about yesterday evening at a meeting of we need to hire more doctors, we need to hire more nurses, we need to get more space. We need to grow, but we're 7,000 team members strong now. And as we grow, and I see us going to 8, 9, 10,000, we have to make sure that everyone's communicating so we can do the best for any patient coming in. It's wonderful that a patient gets to be seen by so many teams, but that also is a challenge of communication. And one thing that, and we're also not even going to be, like right now, Jason's sitting 15 feet from me, so I can easily go over there, knock on his door. But more and more, we're going to be spread out. We're going to try to bring satellites to an area near you soon and everywhere throughout Florida to make it more convenient for patients. And as we do that, our teams will be more spread out. But we're going to need to use technology to work and communicate with each other so that we always have a hub and spoke type communication. But I think technology and things like this, you know, I never heard of Zoom before COVID, and now it's so easy to get onto a Zoom. And so this is ways that we're going to have to try to tighten up that communication. But again, I apologize if you've had any issues.
One thing that I know patients struggle with is fragmentation at different, you know, so you receive part of your care with one doctor and part of your care with Moffitt, or you've seen a doctor outside of Moffitt and then you're seeing someone in, and we really, that's a struggle that we work very hard to try to overcome. I will point to the First Connect callback program that we just started and that you may see advertisements about. The idea there, so if you called Moffitt and said, hey, I want to be seen, we reach out to you within 24 hours and with someone who knows how to integrate the information that you had from your prior treatment with what we would do here. So the idea is that to kind of climb out into your world rather than wait for you to come into the ivory tower, you know. And so that's what we're trying to do, is really get out into the stream of the information that you're getting and really kind of, like I said, climb out into what's on your mind and what do you need, rather than waiting. And I think that's just that's what we can, we're hoping, and we think that that's going to make a big difference. I mean, we often move appointments around to make sure the doctor you're seeing is the correct one, and to get that communication in place. And there are many, many people looking at your record before you even come here. Scores of people, making sure that we get you the best. And so, you know, we're just going to keep working away at it. We're making progress. I think that callback program, by the way, I've never seen that done in my years of taking care of patients. Completely unique. I would say state of the art for communication.
Exciting. Thank you to all of you for your engaging questions, and thank you to Dr. Hwu and Dr. Fleming for your wonderful expertise. I'm now going to turn it back to Maria, who will share our closing remarks. I hope you all enjoyed the Q&A session.
Thank you very much, Liz. And thank you, Dr. Fleming, Dr. Hwu. I just want to say, wow, it's so amazing listening to the work that is happening here. I feel there are so many reasons to be optimistic and hopeful, when we hear about this work. And I wanted to reiterate something you both said, which is that right here in everyone's backyard, work is going on that's not happening anywhere else, and this is a resource not just for Florida, but for the world. And so I always like to say, when you give to Moffitt, you're giving to mankind. And I think when you hear, what we've heard today, we really feel that that's true. We're leading so much of the science. And as Dr. Hwu said, in partnership with you, we can really do something about this in the next 10 years. So, again, I just want to thank you and thank everyone on the call for your amazing support. There will be an email that's going to go out just in case you want to give a bit more and get us over that 200,000. That would be terrific. But I also want to just get Liz Flack to put herself on the camera, because I have to just call out Liz, who many of you may know. She's been organizing this event for many years, and you won't be able to see this, but Liz is heavily pregnant to the point that she is literally about to have her second child. And we were laughing earlier saying she may be in the parking lot of the hospital right now, but I just want to thank Liz.
I'm still here.
I just wanted to thank Liz for just really going the extra mile to arrange this, be a great partner with Eileen. And thank you so much, Liz, for your work on this.
Thank you, Maria, and thanks, Eileen, the whole committee. And we're very, very grateful for you all, especially in this tough year. It's incredible that we're so close to the goal. So it's truly thanks to our wonderful supporters in Sarasota.
Thank you very much, everyone. Have a great day.
Thank you.